Sleep occurs universally across species and is as integral to health as food and water. It involves a toning down of activity to improve rest and restoration, where the body temperature and heart rate fall during periods of highest parasympathetic nervous system tone, and where the brain uses less energy and is least likely to be aroused by external stimuli. Along with learning and memory consolidation during this period, important neuroendocrine hormones are released, including ones that affect vascular health, like lipid metabolism, glucose tolerance, and insulin resistance. Sleep involves a transition through stages, progressing into deeper periods of non-REM than REM sleep. And this must be without excessive arousals or fragmentation for sleep to be restorative. The disruption of these normal cycles of sleep can affect the autonomic nervous system, the hypothalamic pituitary adrenal axis, and vascular control. The potential causes and consequences of untreated sleep disorders before on the left and after stroke on the right are shown here. And the causes of low rates of screening shown here on the left range from the challenges of formal sleep testing in stroke patients with motor and cognitive deficits, especially in laboratory polysomnography, to the uncertainties of timing for sleep testing overall. Whereas the consequences and the presumed mechanisms shown here and here include both increased incident and recurrent stroke, as well as worsened stroke outcome. A recent meta-analysis showed the dynamic prevalence of these two more common sleep disorders after stroke and TIA, including sleep disorder breathing on the left and sleep-wake cycle disorders on the right. And it looked at these after stroke and TIA in the acute setting, less than 1 month, the subacute setting, 1 to 3 months, and the chronic, greater than 3 month setting. Sleep disorder breathing is measured by the respiratory events per hour, or the apnea-hypopnea index, or AHI, and it can be classified as mild, greater than 5, moderate, greater than 15, or severe, greater than 30. And the prevalence of mild sleep disorder breathing or sleep apnea is fairly constant over the time periods, with about 2/3 of all patients having at least mild sleep apnea. Whereas the presence of moderate to severe sleep apnea did change over time in these settings, but remained 25 to 50% of all stroke patients. Overall, there's been less studies on sleep-wake cycle disorders, and they're mostly focused on insomnia. But whether through formal or self-reported questionnaire diagnosis, the range was about 1/3 to 1/2 in all 3 time periods. Looking at sleep-wake cycle disorders, the population-based Women's Health Initiative evaluated the risk of ischemic stroke in relation to self-reported sleep duration among nearly 100,000 postmenopausal women. What they found was that nearly 10% of the population slept less than 5 hours per night. And this rate was actually higher in racial minorities, 7% in whites compared to 19% in blacks and 15% in Hispanics, American Indians, and Asians. On the opposite end, nearly 5% of the population reported sleeping at least 9 hours a night. And then looking at ischemic stroke risk, the lowest risk was seen in those sleeping 7 hours a night. And using that as a reference, there was a U-shaped graded increased risk in those sleeping less than 6 hours, and then those sleeping greater than 7 hours, these two columns on the right. After controlling for many socioeconomic and clinical factors, including cardiovascular disease risk factors, depression, snoring, and sleepiness, short sleep was no longer significantly associated with ischemic stroke risk, but the long sleep remained stable, with about a 25% increased risk in those sleeping at least 8 hours a night, and about a 70% increased risk in those sleeping at least 9 hours a night. And this forest plot from a meta-analysis of 6 studies shows this kind of modest increase of about 15% of developing or dying from stroke with short sleep duration, and this more robust association with long sleep duration. And there's been concern that this increased duration of sleep with ischemic stroke these patients may have underlying sleep disorder breathing because many of these studies didn't really evaluate that very fully. The most common sleep disorder after stroke is obstructive sleep apnea, and it's characterized by repeated upper airway closure or narrowing during sleep. And it's associated with snoring, irregular breathing, and daytime symptoms like headache, fatigue, excessive daytime sleepiness, attention and memory deficits. And individuals can be prone to OSA due to craniofacial structures or enlarged tonsils and obesity. In a meta-analysis of over 2,000 ischemic or hemorrhagic stroke or TIA patients, the presence of OSA with an AHI of 5, just mild sleep apnea, was present in about 3/4 of patients, whereas severe OSA with an AHI greater than 30 was noted in about 1/3. In contrast, predominant central sleep apnea was only noted in about 7% of patients. And despite this high prevalence of sleep apnea after stroke, only about 6% of stroke survivors are offered sleep testing in the 3-month post-stroke period. There are two important caveats to discuss when speaking of OSA and stroke. The first is the chicken or the egg. Does sleep apnea typically precede the stroke, or is it a consequence of the brain injury? And most studies suggest that OSA is a pre-existing condition, noting that stroke and TIA patients show the same frequencies of OSA. And there's really no association between OSA prevalence and stroke severity, location, or etiology. And while sleep disordered breathing does improve over time, like other stroke-related deficits, the reduction is likely related to a decrease in positional sleep apnea and central sleep apnea, where still about 50% of patients have obstructive sleep apnea at greater than 3 months. The second caveat is that stroke patients with OSA are not similar to the typical OSA patients without stroke, and that they're older, they're more gender balanced, they have higher comorbidities like cardiovascular disease risk factors, but also comorbid anxiety, depression, and fatigue. They're also not as overweight and less likely to be sleepy or snore. And these last two factors, the lower BMI and less daytime sleepiness in stroke patients, have major implications for OSA screening, where the typical questionnaires used to screen OSA in clinics functions poorly in stroke patients. So looking at OSA as a risk factor for stroke, an observational cohort study evaluated the composite endpoint of stroke or death from any cause among patients who were referred to a sleep center and were followed for greater than 3 years. And what they found was the probability of event-free survival was significantly lower for those patients with severe OSA, and these patients had a mean AHI of greater than 35, and then patients without the syndrome who had an AHI less than 5. The nearly twofold increase in stroke or death, even after adjusting for cardiovascular disease risk factors, suggesting that OSA was an independent risk factor for stroke and death. The authors also noted a significant trend between the OSA severity based on quartiles of AHI, shown here on the left, with the increased risk of stroke or death, shown here with the hazard ratios on the right. And this was followed by the sleep heart health study. And this time they looked at 5,000 healthy participants and the ones that were not necessarily referred to a clinic. And they followed them for 8 years after a sleep study. And they found that moderate OSA with an AHI of greater than 15 per hour was 30% more common among participants who had an ischemic stroke compared to those who remained stroke-free. They also found a gender difference in the stroke risk with men with moderate to severe OSA with an AHI of greater than or equal to 20, shown here, this bottom line, having an almost 3-fold increased risk of ischemic stroke compared to those without OSA in this top line. And this translated to an estimated 6% increased risk of stroke per unit increase in AHI between 5 and 25. In women on the bottom, there really was not significantly, stroke was not significantly associated with AHI quartiles, but the authors did note a similar 2% increased risk of stroke with each unit increase in AHI, but only for severe OSA, so above an AHI threshold of greater than 25. A meta-analysis of population or clinic-based prospective cohort studies revealed a moderate to severe OSA increased the cardiovascular risk overall, but in particular the risk of fatal or non-fatal stroke. This is shown in the 10 studies here, with about a 2-fold increased risk of stroke And this was much higher than the risk for coronary heart disease. So along with functioning as an independent risk factor for stroke, OSA can also increase the risk of stroke through effects on traditional stroke risk factors, especially hypertension, through high levels of sympathetic activity during apneas and associated blood pressure surges during sleep, which are enhanced further by the arousals and sleep fragmentation. In the Wisconsin sleep cohort study, where about 700 healthy employees were monitored with an in-laboratory polysomnography up front and then monitored for hypertension initially and then at baseline and at 4 years later, they found an association between the baseline AHI, shown here on the left, and the development of hypertension, shown here on the right, where participants even with even moderate OSA compared to those without OSA showed a nearly 3 times the odds of developing hypertension. And even those with mild OSA with an AHI 5 to 15 had about 2 times the odds of developing hypertension at the 4-year follow-up. The effects of the sympathetic activity likely contribute to both the sustained daytime hypertension, but also this blunted response to nocturnal dipping. And this is the normal toning down pattern of sleep where blood pressure typically decreases by about 10% of awake values. And this non-dipping blood pressure pattern has been noted in about 48 to 84% of patients with OSA, and it has increased frequency associated with OSA severity. What about stroke recovery from these numerous post-stroke deficits that leave patients dependent on others or unable to return home, from paresis to neglect and aphasia to problems with coordination or gait? Several observational studies suggest that OSA may be a predictor of poor functional outcome after stroke. In one study that looked at 61 patients with ischemic or hemorrhagic stroke who were evaluated with a polysomnography during their inpatient stroke rehabilitation, 72% of the patients were found to have OSA. And in a multiple regression analysis, OSA was significantly and independently related to functional impairment, both at admission and discharge, based on these lower functional capacities by the functional independence measure, the FIM, as well as an increased length of hospitalization. The gold standard treatment for OSA is continuous positive airway pressure, or CPAP, and it's a mask worn during sleep to splint open the airway. In 2014, the American Heart Association guidelines for stroke prevention in patients with TIA or stroke for the first time recommended sleep studies for treatment with CPAP to be considered based on the high prevalence and evidence of improved outcomes in the general population. However, the most recent 2019 acute stroke guidelines really do not recommend routine screening after ischemic stroke. And this is very much related to these lack of sufficiently powered trials demonstrating the effectiveness of CPAP. And it's left providers without evidence to guide them on who, when, or how to diagnose OSA, and really led to a situation of where it's a matter of who's drinking the Kool-Aid on screening and testing for sleep apnea. So one such multi-center randomized control trial was a SAVE trial, and this looked at 2,700 patients with established coronary artery or cerebrovascular disease and a diagnosis of moderate to severe OSA. And they randomized these patients to CPAP or usual care, but they didn't randomize the stroke patients within the first 90 days unless it was a minor stroke. And after a mean of about 3.7 years, the treatment with CPAP did not prevent recurrent cardiovascular events, including stroke. But one of the main limitations of the SAVE trial was the mean CPAP use was only 3.3 hours per night and didn't meet the study's criteria for CPAP adherence, which is greater than 4 hours a night over the first 2 years, making it really problematic to estimate the actual treatment efficacy. In fact, in a pre-specified propensity score matched analysis did show that participants who did wear the CPAP for greater than 4 hours per night compared to matched participants in the control group did have a lower risk of stroke. These twin issues of being sufficiently powered and demonstrating adequate treatment adherence will hopefully be addressed in the NIH StrokeNet Phase 3 Sleep Smart, which will evaluate in over 3,000 participants the treatment of OSA with CPAP on both secondary prevention at 6 months as well as acute stroke recovery at 3 months. And unlike a SAFE trial, SleepSmart evaluates only stroke and high-risk TIA patients, not participants with coronary disease, and it enrolls stroke patients within the first 2 weeks of TIA or stroke. And also to address issues related to adherence, SleepSmart includes a run-in night of CPAP and also randomizes and only randomizes those who demonstrate initial CPAP tolerance, which they define as 4 hours of use during that one night run-in. It's estimated that only 30% of those with OSA will show that initial CPAP tolerance and undergo randomization. So with that, I thank you for your attention and hopefully have at least convinced some of you to drink the Kool-Aid on OSA testing and CPAP treatment. Oh yeah.
Hi, my name is Brianna Taylor. I'm a vascular neurologist at the University of Washington in Seattle, Washington. I'm here to talk about sleep environment and disparities in stroke risk. I have nothing to disclose. So what leads to health disparities? Well, we really can't talk about this without talking about social determinants of health. The CDC describes this as conditions in the places that people live, learn, work, and play that affect a wide range of health and quality of life risk outcomes. The World Health Organization actually takes it a step further and says that these circumstances are shaped by the distribution of money, power, and resources at the global, national, and local levels. Healthy people separate social determinants of health into 5 categories: health and healthcare, education, access, and quality, social and community context, economic stability, and neighborhood environment. We will focus on neighborhood environment today. This includes access to healthy food options, crime rates, availability of transportation in one's neighborhood, among other things. When we think about social determinants of health, it's helpful to consider this in the socio-ecological model. This graphic is adapted from the National Cancer Institute Center on Public Health and Health Disparities. And I like it because it really shows the complex interplay of these different levels of society. So at the bottom of the graphic, we have proximal factors. And in the case of sleep, environment, and stroke risk, these might include things like sleep hygiene, screen time, individual physical activity, individual health conditions. When we get to the top of the graphic and think about the distal factors, social conditions and policies really go into play here. So if you live in a city that has a city ordinance that says there can be no construction noise or other loud noise from 9 p.m. to 9 a.m., you may have less disrupted sleep than someone who lives in a city that is noisy and doesn't have such an ordinance. We also have to consider the built environment. So the built environment is the neighborhood space around our homes, our work, our schools, that includes residential zoning, healthy food options in the neighborhood, social engagement, social cohesion, and social engagement destinations, things like parks or churches or barbershops, for example. Healthy neighborhoods are those that have increased walkability, they have increased aesthetic appeal, recreational activities, open spaces. It's easy to imagine how even the addition of something like a sidewalk can promote physical activity in a neighborhood. You can contrast this with neighborhoods that have high density of fast food options compared to healthy food options, grocery stores that are affordable versus grocery stores that are not. The graphic here on the right is a representation of the Seattle area and showing low BMI clusters in green and high BMI clusters in red. Coincidentally, or maybe not so surprisingly, these green areas also correlate with higher socioeconomic status compared to the red areas. There's also a difference in racial and ethnic makeup, where more underrepresented minority groups are living in the areas in red. And there's also increased rates of diabetes, hypertension, sleep apnea, and other vascular risk factors in the neighborhoods indicated here in red. Nocturnal environmental noise plays into this built environment risk as well, and is a growing problem in modern cities. The World Health Organization recommends a target or an average of less than 40 decibels of nocturnal noise to prevent adverse cardiovascular or other health risks. Contrast that to what is actually happening, where 1 in 5 Europeans are exposed in a long-term fashion to levels greater than 55 decibels. This can affect sleep architecture and subjective sleep quality, with increased periods of wake and increased stage 1 sleep, as compared to the restorative portions of sleep, the slow wave sleep and REM sleep. It's also thought that nighttime noise may have a greater effect on cardiovascular risks than daytime exposure. When we think about sleep and the environment, as I've mentioned before, it's a really complex interplay of lots of different factors. We know that there's residential segregation along many lines, including socioeconomic status, race, ethnicity, immigration status, especially with the advent of practices like redlining, and also segregated by neighborhood disadvantage or deprivation. This directly plays into the social environment. These economic status often pay less taxes and therefore have less resources to increase things like public spaces, walkability. Businesses don't tend to open in those areas. There are also concerns about violence and safety and crowding. Those crowding and other sort of increased population density effects can affect things like noise, light pollution, air pollution, all of which can add to the stress of just living in a neighborhood. That stress can have poor outcomes on sleep, including increased rates of insomnia, sleep disruption, delayed sleep, or insufficient sleep. And they also can have an effect on activity. Physical activity is a risk, or decreased physical activity is a risk for obesity, which, as we know, is also a risk factor for sleep apnea. There are many things that can confound this association, like age and gender or sex, risk factors like diabetes or hypertension, health-related behaviors like smoking or alcohol use. But these changes in sleep architecture and sleep quality, along with stress, can have biological effects as well, affecting the neuroendocrine system, affecting the hypothalamic pituitary adrenal axis, and also increasing vascular control via increased adrenaline secretion. It's important to think a little bit about geocoding as we go into talking about some of the studies that have looked at this. Geocoding is a process of assigning a specific code to a geographic location, and in turn, coordinating that code with information about the variable or the outcome of interest, in this case, sleep and stroke risk. I should also mention that this is typically done using census data, and census tracts are established that can group patients together based off of their neighborhood characteristics. For example, in King County, there are about 400 census tracts and about 4,000 people in each of those tracts. This was a study using data from the MESA cohort. The MESA population includes participants who were recruited in the early 2000s without vascular risk factors, cardiovascular risk factors, and followed over time. They hail from 6 United States cities, as indicated here in the graphic, and neighborhoods were defined in this particular sub-study using census tract data. They included about 6,000 patients that were participating in the MESA cohort, ages 45 through 84. They evaluated the built environment, including things like walk score, population density, social engagement, street connectivity, number of intersections. And they also gathered survey-based data about other neighborhood metrics like neighborhood level noise. The participants all did 1 week of wrist actigraphy, which is the gold standard evaluation for sleep state. And what they found was that neighborhoods that had higher walkability, increased population density, increased social engagement, there was actually a 23% higher odds of short sleep for each increase in standard deviation of that walkability score. This was true in models that adjusted for age, sex, a variety of stroke risk factors, sleep risk factors. But when they included a model that took into account neighborhood level noise, this association actually became attenuated. Neighborhood noise was correlated with higher walkability, and so perhaps the neighborhood noise is the reason for this finding. The second population I wanted to talk about was a subset of the Jackson Heart Study. The Jackson Heart Study is a population-based prospective cohort study examining cardiovascular risk and the etiology of cardiovascular disease in African Americans in Jackson, Mississippi, involving 3 counties in that area. Patients were ages 21 through 95, and about 5,000 people were included in this study. They used self-reported neighborhood social cohesion data through surveys. They also asked participants about perceived violence in their neighborhood and also problems. These problems could be defined as things like litter or just disorganization in general in the patient's opinion. And then they separated them, those problems, into either tertiles or dichotomous variables depending on each one. Overall, this cohort reported 54% of the participants had less than 6 hours of sleep per night, and about a quarter of them reported poor sleep. When they looked at the social cohesion data, there was actually no association really between the social cohesion measures and short sleep. But when they evaluated for the participants thought about violence, whether it was low or high in their community, there was an 18% higher odds of short sleep among people who felt that their neighborhood had high levels of violence, and about 10 minutes less sleep in that group as well. Similarly, the problems reported, whether they're low, middle, or high in their community based upon census-derived data, was not associated with any particular sleep outcome. When we look more closely at the group in the study who reported low sleep quality, they were more likely to be less educated and of lower income. The authors of the paper did mention that this may be related to higher incidence of sleep work in those groups of patients, and also potentially lower socioeconomic status, and also related to increased rates of depression, which had been shown in another ancillary study. When they looked more closely at the neighborhood violence metric, the short sleep was actually present in males, but not in females. So there was a modification by sex in this lower sleep quality group as well. The last study that I wanted to mention is a study that used data from the Regards cohort to evaluate neighborhood characteristics in stroke. You may know that the Regards cohort is a population that was recruited between 2003 and 2007. Both Black and white patients were included, and the patients were recruited from the stroke belt and the stroke buckle, which is a large portion of the southeastern United States where stroke rates and stroke mortality are quite high. These patients were geocoded into census tracts, and neighborhood socioeconomic status and ischemic stroke rates were evaluated, and there was they controlled for individual socioeconomic status. They then broke this down into tertiles, with the first tertile, quartiles, with the first one being lowest socioeconomic status, neighborhood socioeconomic status, and the fourth one being highest neighborhood socioeconomic status. After following these patients for a mean of 7.5 years, there was about a 4% rate of ischemic stroke overall. But when they looked at the stroke rates separated by quartile, they found that there was a linear trend between increasing rates of ischemic stroke and decreasing neighborhood socioeconomic status. This persisted even after adjusting for age, sex, and individual socioeconomic status. When they adjusted for stroke risk factors, however, that interaction became non-significant, with more attenuation being observed in Blacks compared to whites after the risk factor adjustment. The authors concluded that the neighborhood socioeconomic status contributes to stroke risk beyond the individual socioeconomic status. And the fact that these biological risk factors substantially attenuated the association suggests that there are worse biological risk factors in those lower socioeconomic status communities. And perhaps this is a mechanism for higher rates of stroke in those communities. This is something that's obviously being looked at in the United States, as I pointed out in the prior studies that we've talked about, but there are a number of registries and population-based cohort studies going on in other countries that are demonstrating the same. And I just wanted to highlight this one study from Japan, the Japan Public Health Center-based Perspective Study. Again, a large sample size and using census-derived data. And they found essentially the same thing as described in that regards subset, where living in a more deprived neighborhood increased the stroke risk regardless of an individual socioeconomic status. Behavioral and psychosocial factors did attenuate the results, but they remained significant. So bottom line, if we want to be able to promote health equity, we have to understand the complex interplay of some of these more systemic issues, and neighborhood environment is one of them. Thank you so much to ISC for having me today, and thank you to Sandeep Coat for inviting me to speak on this topic. My email is included here on the slides if anyone has any other questions. Thank you.
Hi, thanks for the opportunity to present today. I'm going to talk about sleep, cerebrovascular dysfunction, and brain health. So we know that sleep disorders are common in dementia, and nearly half of all AD patients experience impaired sleep. Sleep deficits in Alzheimer's disease include abnormalities in sleep architecture, as well as a higher prevalence of sleep disorders. And these are not only an issue for the dementia patient, but also an issue for caregivers as well. But associations between sleep and dementia might be bidirectional, and that is deficits in sleep or dysfunction in sleep might increase risk for dementia, but then also neurodegeneration might lead to deficits in sleep as well. And there's been a lot of focus on the role of lymphatic clearance, and particularly with respect to amyloid beta and amyloid beta clearance. But less research looking at sleep dysfunction and vascular contributions to dementia. I think the most obvious point to start is that of sleep apnea and sleep disordered breathing and its association with stroke, because that has been studied quite extensively. This is a meta-analysis looking at prospective cohort studies and combining them to see whether sleep apnea associates with higher risk of stroke. And if you look at the pooled effect down the bottom, you can see that having sleep apnea versus not having sleep apnea associates with about a twofold increase in the risk of stroke. Researchers also extended this to look at sleep apnea and small vessel disease markers using MRI. And again, another meta-analysis shows significant associations between sleep disordered breathing and presence of white matter hyperintensities, silent brain infarcts. Although interestingly, this study found no associations with cerebral microbleeds and perivascular spaces. This study, the SAVE trial, published in the New England Journal of Medicine, looked at whether treatment of sleep apnea could prevent cardiovascular events. And interestingly, they found that treatment of sleep apnea with CPAP versus usual care did not prevent stroke in patients with moderate to severe OSA. So just an interesting finding showing that although we see these associations in prospective studies, treatment of sleep apnea might not necessarily have the intended effects. Although OSA, obstructive sleep apnea, increases risk of stroke in prospective studies, stroke itself might lead to disruptions in sleep as well. This is research by one of my PhD students who's now submitted, Ali Gottlieb, together with Amy Brodman and Mark Howard. And we looked at sleep-wake dysfunction after stroke. And we sort of thought that sleep-wake dysfunction could be driven both by the focal infarction as well as more widespread neurodegeneration after stroke in sort of sleep-wake areas. Various insults to the brain are associated with sleep dysfunction, whether it be a traumatic brain injury or a stroke. And so we examined regional brain volumes and fiber-specific white matter differences in patients with stroke who reported sleep-wake dysfunction and compared them to a healthy control cohort. And we found that stroke patients with excessively long sleep duration or poor sleep efficiency, so essentially stroke patients with some evidence of sleep dysfunction, they had smaller regional brain volumes, particularly in the ipsilateral thalamus, ipsilesional thalamus and contralesional hippocampus, as well as contralesional amygdala as well. And they also had stroke patients with long sleep duration exhibited neurodegeneration to the corticopontocerebellar tract and had poorer post-stroke recovery, suggesting that there might be anatomical correlates of sleep-wake dysfunction in stroke patients due to more sort of widespread neurodegeneration in areas beyond their focal infarction. Sleep apnea, as mentioned, was associated with a high risk of stroke and small vessel disease markers. In turn, stroke and small vessel disease are associated with a high risk of dementia. So you could hypothesize that perhaps sleep apnea would be associated with a high risk of vascular cognitive impairment, independent of overt stroke. Indeed, patients with Alzheimer's disease do tend to have a high prevalence of OSA at around 40 to 70%. But there's mixed evidence as to whether obstructive sleep apnea associates with a high risk of dementia. The study of orthopedic fractures, which followed elderly women with moderate to severe, they found that patients with moderate to severe obstructive sleep apnea were 85% more likely to go on and get MCI or dementia as a combined outcome after about 5 years of follow-up. However, the atherosclerosis risk in the community study did not find a consistent association between obstructive sleep apnea and the risk of dementia or cognitive decline measured over the following 15 years. And our research in the Framingham Heart Study, we tend not to see an association between the apnea-hypopnea index and dementia risk in our cohort. On the right, though, you can see this figure showing that OSA is associated with increases in amyloid beta over time, which is quite interesting. So there might be multiple mechanisms linking obstructive sleep apnea or sleep disordered breathing to brain health beyond just sort of deficits in blood flow to the brain and sort of ischemic brain injury. This is research by one of my postdocs, Andrea Young. I co-supervised Andrea Young with a number of other people. She's now in Canada, but has been working on the Framingham Heart Study. She hypothesized that perhaps only a subsample of people with obstructive sleep apnea might be at higher risk of dementia, and is particularly interested in interactions between inflammation and obstructive sleep apnea and the relationship with dementia. And indeed, she found significant interactions in the Framingham Heart Study between people's levels of peripheral inflammation and the apnea-hypopnea index, such that greater obstructive sleep apnea severity only associated with a higher risk of Alzheimer's disease in people with low levels of peripheral inflammation, which was quite interesting. And these results sort of require further replication and investigation to understand. There's been a lot of research looking at lymphatic flow and associations between lymphatic flow and amyloid clearance, for example. I'm sure most of you are familiar with this work published in Science, looking at how sleep drives metabolic clearance in the adult brain. But there's been less research looking at slow wave sleep and markers of small vessel disease. So most of the lymphatic flow is hypothesized to occur in slow wave sleep, but we were interested in looking at slow wave sleep and its association with markers of brain health using MRI. And again, research by Andrea, which has just come out in neurology. We studied about 500 people with a brain MRI scan and an in-home PSG. And we found that people with longer slow wave sleep duration had higher cortical and subcortical brain volumes. And interestingly, they had lower white matter hyperintensity volumes as well. But slow wave sleep duration did not associate with hippocampal volume, and sort of atrophy to the hippocampus is often associated as an early change with Alzheimer's disease. So quite interesting that we see these associations between slow wave sleep and white matter hyperintensities, but not necessarily with hippocampal volume. So essentially finding that more slow wave sleep associated with evidence of a healthier brain. In another study, we looked at aspects of sleep architecture and risk of developing dementia over time. And we hypothesized that having more slow wave sleep would associate with a lower risk of going on to get dementia. So this was a subset of that sample I just mentioned. So we had participants in the Framingham Heart Study, but we followed those aged over 60, given that dementia is a condition of old age, and we followed them up for 12 years after their PSG. Interestingly, though, we didn't find any associations between slow wave sleep and dementia, but we did find associations with REM sleep. So each percentage reduction in REM sleep associated with about a 9% increase in the risk of getting dementia, taking longer to enter REM sleep, so REM sleep latency, associated with the high risk of dementia, and having more arousals from sleep associated with the high risk of dementia as well. And these associations are quite large, so each percentage reduction in REM sleep associated with about a 9% increase in the risk of getting dementia. The slide's a bit busy, but essentially it's just looking at associations between REM sleep and dementia when you exclude for certain factors. And so if we exclude people from our cohort who have a high number of arousals in REM sleep due to sleep disordered breathing, so due to hypopnea or apnea, the estimates that we see don't really change, suggesting that associations between REM sleep and dementia are independent of sleep disordered breathing. And again, we're looking at dementia occurring in the future up to 12 years later, so quite an interesting finding. We've also done research looking at sleep time and dementia risk. I mean, there's been quite a lot of research looking at both short sleep time and long sleep time and risk of dementia. What was unique about our study was that we measured sleep time multiple times in people's lives, and we were able to quantify changes in sleep time and how changes in sleep time associated with the high risk of going on to get dementia in the next 10 years. And we found that people who were long sleepers, so sleeping more than 9 hours a night, had a twofold increase in the risk of dementia versus people who slept for normal amounts. Interestingly, we didn't find any associations with short sleep duration. But I think one of the most interesting findings was that if you were always a long sleeper, so if at multiple time points in one's life, if they reported sleeping more than 9 hours, there was no association with risk of dementia. But participants who transitioned from being a normal sleeper at one point in time to then becoming a long sleeper had a 2.5 or 2.4 increase in their risk of going on to get dementia, suggesting that maybe changes in sleep or changes in sleep time and increasing sleep need might be sort of more of a marker or something going wrong in the brain. And that was kind of confirmed by this, where people who had both problems with thinking and memory, they reported problems with thinking and memory, and they had, or they reported long sleep time, these people had a 6-fold increase in their risk of getting dementia. I guess what's of relevant to this talk is that the cognitive profile of these people was more sort of executive rather than ethnicity. We found associations between actually both short sleep time and long sleep time with poorer executive function, but we didn't see those associations for memory. And if we looked at, say, performance on the trail-making test, the difference between someone who was a long sleeper versus normal sleeper in terms of their trail-making performance was equivalent to about 12 years of brain aging. So we really need more research now to sort of tease apart these associations and to look at to sort of what extent dysfunction in sleep is associated with poorer sort of neurological outcomes in terms of neurodegeneration, risk of dementia, and the contributions of small vessel disease to that and vascular dysfunction versus other pathways. Recently, we've started this initiative, which is a sleep and dementia consortium funded by the NIA. It's led by myself and Jay Andrew Himali at the University of Texas at San Antonio, but has participation from multiple experts in the area and multiple community-based cohort studies in the USA. And we have almost 3,000 people who have an overnight PSG and follow-up for risk of dementia. And so we're going to look at what aspects of sleep most strongly associate with risk of incident Alzheimer's disease, as well as other forms of dementia, and try and really better understand the specific aspects of sleep that drive these associations. Now, we also have about 7,000 people who have both an overnight PSG and brain MRI or cognitive assessments. And many of our cohorts also have changes in sleep over time because these cohorts have multiple PSGs. And so we're able to look at how changes in sleep biomarkers over time relates to changes in brain health as well, which I think is going to be really interesting. So we're really just getting started and starting to plan our analysis as we move forward. And we have participation from the Chromium Heart Study, Cardiovascular Health Study, the Atherosclerosis Risk in the Community Study, as well as the SOF and Mr. Ross cohorts as well. So to summarize, sleep dysfunction is linked to many mechanisms associated with poor brain health. Sleep disordered breathing associates with risk of stroke and small vessel disease markers, but associations with dementia are less clear. Slow-wave sleep disruption may associate with small vessel disease biomarkers, but more research is really needed to tease apart the contributions of poor sleep to vascular cognitive impairment. So I'd just like to end by thanking my lab and my key collaborators. Thank you very much.